we will discuss how to ask an answerable research question. This is the second topic in our research design course. The goals of this talk are to review where good research questions come from, identify the components of a good research question, determine if the research question is answerable, and discuss the following steps. Good research questions can come from a variety of sources. They may come from clinical controversies, challenging the existing standard or processes, interesting clinical observations, new technology, diseases, or methodologies, expanding or improving upon existing research, or from attending research conferences. We will look at each of these in greater detail in the coming slides. Clinical controversies often exist when there's an absence of evidence to guide clinical decision-making. Sample research questions could include, when should a patient with a sports concussion return to full school and physical activity? Is a central line necessary in pediatric patients with septic shock? And should mannitol or hypertonic saline be used in the management of increased intracranial pressure in the head trauma patient? Good research questions is to challenge the existing standard. The phrase, "we've always done it this way," without evidence to support the approach, is an opportunity. In the management of croup with nebulized epinephrine, the existing dogma is that patients should be observed for 4 hours after epinephrine and admitted to the hospital if they require more than one epinephrine treatment. 2 recent studies have refuted these standards. Interesting clinical observations may also serve as a source for research questions. We treat patients with hyperemesis gravidarum with D5 normal saline to reverse catabolism and ketosis. We hydrate children with persistent vomiting and large ketones who are clinically dehydrated. Those 2 observations could lead to the question, should we treat children with large ketones with dextrose containing normal saline? New technologies and diseases represent opportunities for novel research. Is intranasal epinephrine as effective as intramuscular epinephrine for anaphylaxis? What is the spectrum of disease in children with monkeypox or Marburg virus or any new infectious agent? Can artificial intelligence be used to interpret point-of-care ultrasound images? There is always an opportunity to expand upon existing research. Can you improve on the design? If it was an observational study, can you do an interventional study? If it was done retrospectively, can you do it prospectively? Consider a meta-analysis if multiple studies on the same topic exist that do not definitively answer the research question. You can also study the question in new populations or settings. You can conduct a multi-center study if only a single-center study exists. Are the results the same in the community hospital setting as in an academic setting? You can also advance the stage of a clinical decision rule. If it has been derived only, you can validate it. If it has been validated, you can conduct an impact analysis. Research-oriented conferences can be a great source of research questions. What has been the focus at the conference? Recent areas of interest in pediatric emergency medicine include point-of-care ultrasound, simulation, patient safety, and burnout wellness. What still needs to be answered in those areas? You can study new and exciting areas such as the application of artificial intelligence to clinical decision-making. Research conferences also serve as an opportunity to make contacts and meet potential collaborators. Keep track of when national, regional, local, and institution conferences occur. Of the major pediatric and emergency medicine conferences, the academically oriented conferences occur in the spring. These include the Pediatric Academic Societies and the Society for Academic Emergency Medicine conferences. The more commercially oriented conferences occur in the fall. These include the American Academy of Pediatrics and the American College of Emergency Physicians conferences. Multiple other subspecialty and topic-based conferences also occur. These include the American Heart Association, the Society for Simulation in Healthcare, and the Association for Medical Ultrasound, among many others. This was a research question that one of our former fellows developed. We will use it to illustrate how to format a research question and determine if it is answerable. The hypothesis was that dextrose-containing intravenous fluids are superior to a fluid bolus without dextrose in dehydrated patients with ketonuria. The rationale behind the hypothesis was that patients with dehydration and large ketones will reverse their ketosis faster if given dextrose. and will be better able to tolerate an oral fluid challenge after rapid intravenous rehydration. Part of answering an answerable question is determining the focus of the question. The question focus will inform your search strategy. Background questions are disease-oriented. For example, what is the microbiology of acute gastroenteritis in children? Foreground questions are patient-oriented. They focus on clinical care decisions regarding treatment, diagnosis, harm, and prognosis. For example, do probiotics decrease acute gastroenteritis severity and duration in children? The answer to background questions are frequently found in textbooks or the electronic equivalent to textbooks. The answer to foreground questions are frequently found in the medical literature, and we need to search literature databases such as Medline. Foreground questions are frequently divided into treatment, harm, diagnosis, and prognosis. Treatment questions are about the effect of an intervention or exposure on an efficacy or positive outcome. In contrast, harm questions are about the effect of an intervention or exposure on a safety or negative outcome. Diagnosis questions are about the effect of a diagnostic test or decision rule in distinguishing those with and without disease. Prognosis questions are about the effect of a factor on their future course of disease. The PICO format was devised primarily for treatment questions and requires modifications for other types of questions. For a treatment question, P is for the patient or population, I is for the intervention, C is for the control, and O is for the outcome. You can also add a D for PICOD for design of the study and or the database where you're to likely find the evidence. Why PICO? PICO clearly defines the elements of the question and translates the question into searchable terms. Your patient population will help define inclusion and exclusion criteria, specify age, gender, setting, and disease severity or the chief complaint. For example, moderate to severe asthma or right lower quadrant abdominal pain with peritoneal signs. The population in the dextrose study was children or young adults presenting to the emergency department with moderate dehydration based on a validated score with a clinical diagnosis of acute gastroenteritis defined as vomiting and/or diarrhea without another cause identified with a symptom duration of less than 7 days. It is very helpful to use definitions that have been established in the medical literature so that your results can be compared. We used a consistent definition of acute gastroenteritis from the medical literature. In the dextrose study, the P for patients is children and young adults with moderate dehydration due to acute gastroenteritis in the emergency department. The intervention in the dextrose study was an intravenous fluid bolus of 20 mL per kilo of 5% dextrose in normal saline over 1 hour with a maximum bolus of 1 liter. A control group may not be necessary in case series or pilot studies. For therapy studies, the question may be a placebo or an alternative treatment. The control in the dextrose study was an intravenous fluid bolus of 20 mL per kilo of normal saline without dextrose, administered over 1 hour with a maximum bolus of 1 liter. In the dextrose study, the I for intervention is an initial fluid bolus of 20 mL per kilo of D5 normal saline, and the C for control is an initial fluid bolus of 20 mL per kilo of normal saline. There are often co-interventions separate from the study intervention and control. Ideally, the co-intervention should occur at the same frequency in both groups. For example, in the study of ketamine compared to no ketamine in patients with critical asthma, co-interventions may include inhaled bronchodilators, corticosteroids, intravenous magnesium, and non-invasive ventilation. A co-intervention in the dextrose study was a second intravenous fluid bolus of 20 mL per kilo of normal saline after the initial study bolus in both study groups. If this study were to be conducted today, we would have included intravenous ondansetron as a co-intervention. Outcomes should be easily measurable and clearly defined with a specific time frame. Use existing validated scoring systems for outcomes if possible. Outcomes should be patient-oriented rather than disease-oriented. For example, the initial statin studies used an outcome of a decrease in cholesterol. It was only later studies that established a decreased cardiovascular risk. Outcomes should also be consistent with the existing literature. If migraine studies use pain relief in 2 hours as an outcome, your migraine study should use it also. The primary outcome of the Dexter study was the ability to tolerate an oral fluid challenge after initial fluid bolus of 40 mL per kilo. This included the study intervention and co-intervention. An oral fluid challenge was defined as 10 mL per kilo of oral clear fluids within 30 minutes with a maximum of 4 ounces. Secondary outcomes included resolution of dehydration using a validated scoring tool and admission to the hospital. Admission was at the discretion of the treating physician, but specific indications for admission were collected to address some of the variability in the admission decision. In the Dexter study, the O for outcomes are tolerate an oral fluid challenge, resolve dehydration, and be discharged from the ED. What about the D for design and database? The design was a randomized clinical trial with a superiority hypothesis. The elements of your PICO or PICOD question can be used to inform your search terms. Patient characteristics can be filtered or limited, for example, by age. The intervention, control, and outcomes can be searched as medical subject headings or text words. You can also search for studies that would best answer the questions and in the database most likely to contain the studies. In this example, we could search the Medline database or the Cochrane Clinical Trials Registry for randomized clinical trials. In addition, we could search the Cochrane database of systematic reviews for meta-analyses. PICO was designed for treatment studies and specifically randomized clinical trials. It requires some modification to be used for diagnosis, harm, and prognosis studies. In a therapy study, P is for the patients or population. In a diagnosis study, P is a patient with a suspected disease. In a harm study, P is an exposed patient. In a prognosis study, P is patients with a disease. I is for intervention. In a therapy study, I is the experimental intervention. In a diagnosis study, I is the diagnostic test or decision rule. In a harm study, I is the exposure. In a prognosis study, I is the prognostic factor. I find it helpful to think of a risk factor as a factor associated with the presence of disease, and a prognostic factor as a factor for the development of a disease consequence. For example, smoking is a risk factor for developing lung cancer. Lung cancer staging is a prognostic factor for mortality from lung cancer. C is for control. In a therapy study, C is a comparison to the intervention. In a diagnosis study, C is the reference standard, also known as the gold or criterion standard. In a harm study, C is no exposure. In a prognosis study, C is no factor. O is for outcome. In a therapy study, O is typically an efficacy outcome. In a diagnosis study, O is the test or rule characteristics. In a harm study, O is a harm or safety outcome. In a prognosis study, O is disease consequence, for example, survival over time. This is an example of a diagnostic test accuracy PICO question. P is the patient with a suspected disease, I is the diagnostic test, C is the reference standard, and O is the test performance. For example, in patients with suspected appendicitis, what are the test characteristics for a CT scan with IV and PO contrast compared to a reference standard of operative report, biopsy, or clinical follow-up? The PICO for a clinical decision rule follows the same pattern as the PICO test with the word rule and add resource utilization to the outcomes. For example, in patients with suspected appendicitis, what history, laboratory, and examination findings, when compared to operative report, biopsy, or clinical follow-up, are accurate in distinguishing those with and without appendicitis? This is an example of a harm PICO question. P is a patient at risk for an exposure, I is the exposure, C is no exposure, and O is the harm outcome. For example, are infants receiving the rotavirus vaccine when compared to those not receiving the vaccine at higher risk of intussusception? This is an example of a prognosis PICO question. P is a patient with disease, I is a prognostic factor, C is no prognostic factor, and O is the disease consequence over time. For example, do patients with neuroblastoma with stage 4S disease, when compared to stage 1 disease, have a lower rate of 5-year survival? In summary, PICO assists in clearly defining each aspect of the clinical or research question. These definitions can be used to inform your search strategy. Adding a D for PICO can further refine the search to the appropriate study design and database. PICO is designed for therapy questions and requires some modification for other types of study questions. Once we have formatted the research question with PICO, the next step is to determine if your research question is answerable. The finding criteria determines if the question is answerable. F is for feasible, I is for interesting, N is for novel, E is for ethical, and R is for relevant. We will discuss each of these in detail in the coming slides. Feasibility is about resources. Are there sufficient staff, patients, research assistants? Is there buy-in from your colleagues and the nurses? Will they agree to follow the study protocol? Are there sufficient patients to meet your required sample size? Determine if there is an adequate number of patients in the time frame that you have available. Consider that a proportion of patients will decline consent and that some may be lost to follow-up. Do you require funding, have the necessary equipment, and time to complete the study? For the dextrose study, it's important to remember that it was designed prior to the rotavirus vaccine and Zofran, and that many patients were intravenously hydrated. We determined that there was enough patients in one season to meet our target enrollment. The study was a minor deviation from existing practice, so there was buy-in from the faculty and nurses. In addition, no funding was needed as all the study resources already existed in the Pediatric Emergency Department. Is your study question interesting enough to maintain effort and overcome the inevitable obstacles? Is it interesting to your target audience, your peers and colleagues? Is it interesting enough to be accepted for publication? Of course, the dextrose study was interesting. We thought of it. Is the question novel? Will it provide new evidence or expand on previous evidence? Expanding on previous evidence may include confirmatory studies, extrapolation to new populations or settings, or a systematic review and meta-analysis. Determining if a research question is novel requires searching the medical literature, which happens to be the topic for our next session. For the dextrose study, our literature review revealed that there were many studies on oral rehydration with the beneficial role of dextrose. There were few studies on rapid intravenous rehydration, and no studies on rapid intravenous rehydration with dextrose. Is your research question ethical? Does it meet the ethical standards for human subjects research? Does it deviate from acceptable standards of care? A placebo-controlled pain study in patients with fractures would not meet that standard of care. Does the risk to the study patients exceed the potential benefits? This includes physical and psychological risks and risks to their protected health information. We will explore this topic in greater detail in 2 sessions later in the course when we talk about writing a research proposal for the IRB and research ethics. For the dextrose study, potential benefits included more rapid clinical improvement and potential discharge from the ED. The study required minimal deviation from the standard of care. A theoretical risk was the potential for transient hyperglycemia, which could result in osmotic diuresis and reflex hypoglycemia. We plan to monitor urine glucose for this. The research proposal was accepted by the IRB and full consent was obtained from parents and assent from applicable children. And finally, is your research question relevant? Will it expand on the existing evidence? Does it have the potential to improve patient care by influencing clinical practice or health policy or guide further research? We thought that the dextrose study was relevant and had the potential to impact clinical care. This was a common clinical scenario at the time of the study, often resulting in hospital admission. Discharging patients from the ED keeps families together, reduce lost productivity from school and/or work, and with a potential cost benefit. We have produced a research question, formatted with PICO, and found it to meet the finer criteria. What are your next steps? Now it's time to refine the initial research question. Discuss your idea with potential collaborators, your research mentor, and necessary experts or consultants. Review the existing literature to determine where your question fits in or if it requires modification. Writing the research proposal is the best way to crystallize your thoughts. Determine the best study design to answer your questions. Submit your research proposal to the IRB or a grant funding agency. So on to our questions. What is the appropriate outcome for a search question for a diagnostic test accuracy study when formatting it using the PICO mnemonic? patients, populations, intervention, control, and outcome. Disease prevalence, disease severity, the criterion standard, test characteristics, or disease incidence. The answer is D, test characteristics, sensitivity, specificity, predictive value, and likelihood ratios. The appropriate PICO criteria for a diagnostic test study is P is a patient with suspected disease, I is the diagnostic test, C is the criterion standard for disease, and O is the operating characteristics for the diagnostic test. What is the appropriate intervention for a research question for a prognosis study when formatting a question using a PICO mnemonic? Disease prevalence, disease severity, the criterion standard, test characteristics, or disease incidence? The answer is D, test characteristics, sensitivity, specificity, predictive value, and likelihood ratios. The appropriate PICO criteria for a diagnostic test study is P is a patient with suspected disease, I is the diagnostic test, C is the criterion standard for disease, and O is the operating characteristics for the diagnostic test. What is the appropriate intervention for a research question for a prognosis study when formatting a question using a PICO mnemonic? Disease prevalence, prognostic factor, time, Kaplan-Meier survival curve, or disease incidence? The answer is B, prognostic factor. In a prognosis study, a patient with a disease is followed over time to determine if they develop a complication of disease, for example, mortality. These are often called time-to-event analyses. The appropriate PICO criteria for a prognosis study is P is the patient with a disease, I is the prognostic factor, C is no prognostic factor, and O is the disease outcome over time. A study is designed to determine the effectiveness of oral hydrocodone for ear pain related to acute otitis media. Patients are randomized to receive hydrocodone or a placebo. Which of the finer criteria does this validate? Feasible, interesting, novel, ethical, or relevant? The answer is D, ethical. Placebo-controlled studies of pain relief are unethical. The standard of care in patients with acute otitis media is to provide analgesics in addition to antibiotics. A more appropriate study design would include a comparison of hydrocodone to acetaminophen or ibuprofen. A first-year pediatric emergency medicine fellow wishes to study the impact of the protein conjugate pneumococcal vaccine, Prevnar, on the epidemiology of occult bacteremia in children 3 to 36 months of age with fever. Which of the finer criteria does this violate? The answer is A, feasible. While this is certainly an interesting and relevant question, it would be very difficult from a feasibility standpoint. To determine the bacteremia rate with a reasonable small confidence interval would require many patients. In addition, current recommendations suggest that it is unnecessary to evaluate patients who have received the primary series of Prevnar for occult bacteremia, further limiting the number of potential patients to be enrolled. Our next subject will be searching the medical literature.